Hello everyone. It is my pleasure to be here with you today, and thank you so much for coming. It's Monday. Monday's a little tough. Afternoon hours can be sleepy, but I'm hoping that I can entertain you with some of the findings in PLS study and give you some ideas where this field is moving to. My name is Ikjae. I'm an assistant professor of neurology at Columbia University, Eleanor and Lou Gehrig ALS Center. I was trained in Cincinnati for neurology and neuromuscular medicine. And I moved down to UAB, University of Alabama at Birmingham. I was the co-director of the ALS clinic for 4 years there. And I joined Columbia University in the height of pandemic in 2020. The reason I joined Columbia was to really heighten my research in ALS and motor neuron disease. I was really fortunate to meet many excellent mentors, including Dr. Hiroshi Mitsumoto, Dr. Neil Schneider, and I was able to get fundings from AAN, American Academy of Neurology, and subsequently from the NIH K23 Career Development Award, and really focusing on my research in motor neuron diseases. Most recently, I am working closely with Spastic Paraplegia Foundation, and thankfully, they're supporting for doing more work in primary lateral sclerosis. And without further ado, I'd like to give you some interesting story and thoughts about PLS. I know all of you are very familiar with PLS. This is a brief disclosures, received these fundings and some consultations from pharmaceuticals, but nothing really affecting the talk today from the pharmaceuticals. So let me start from a little bit of history here. Some of you may have already heard how PLS has been evolved as a diagnosis. From my literature search, I really see that the very early description of PLS came from our famous neurologist from France, Jean-Marie Charcot, who's commonly referred as father of the modern neurology. In that era, he described ALS cases and really coined the term amyotrophic lateral sclerosis from the pathology. And he also described two cases in the late 1800s, around 1875, what appeared to be cases of PLS, and he described in pathology of the spinal cord primary sclerosis of the lateral column, meaning hardening of the lateral side of the spinal cord. And in the similar time frame, there was another neurologist, Wilhelm Erb, who made this elegant description of PLS. What he described is that PLS usually begins slowly and insidiously, with some sense of weight, dragging, and slight feebleness in one or the other leg without pain. The condition progressed just as slowly as it commenced. The legs become stiffer and heavier, the gait progressively more labored, dragging, and distinctly spastic. Occasional muscular cramps and contraction of the legs may occur, but nothing else. Objective examination reveals the characteristic symptom triad, a certain weakness, awkwardness of movement of the legs, very slight, so that often for a long time, nothing in the way of paresis, much less paralysis is present. No ataxia, but far more distinct and prominent are the spasm and rigidity of the muscles. And thirdly, the well-marked exaggeration of tendon reflexes with involuntary clonus of the foot while the patient is sitting. So when I read this was so well described. I don't think anyone can describe better than this of the PLS patients, all the variety of patients we still see in our clinic. I thought it was remarkable. And then there was a series of observations reported in 1990s. For example, in 1905, Spiller described 8 cases with autopsy data. Swang and Putnam published 19 cases from the Neurological Institute in New York. Stark and Morse described 43 cases from the Mayo Clinic. So you can see that since these initial descriptions, a lot of other neurologists described similar cases from all across the country. And then what they commonly noticed is that corticospinal degeneration, meaning that your motor neuron pathway from your brain to the spinal cord gradually degenerated, however, largely sparing anterior horn cells, those motor neuron cells in the spinal cord. Now, just to give you a little bit more idea, some of you may not be familiar with all the neuroanatomy. If you look at the figure on the right side, that's the diagram of our motor system. So you can see that in the brain on the top, those upper motor neurons or cortical motor neurons come down from your motor cortex with the cell bodies in there with long axons in the tract coming down the cerebral peduncle that's in the midbrain, and then also passes through pons and medulla. Those are the brainstem structure. It decussates, meaning crossover to the other side, and then further go down to synapse, meet with the anterior horn cells. That's a lower motor neuron. So that's describing the upper motor neuron tract from motor cortex all the way down to anterior horn of the spinal cord, where the anterior horn motor neurons are the lower motor neuron. That's a separate system, the second system. Further send out axon to the nerve, and finally its synapses, it meets with your muscle. So our motor system is a two-tier system. The first system from your brain to your spinal cord, the upper motor neuron system, and the lower motor neuron system is the anterior horn to your muscle, the lower motor neuron system. And why is that important? Depending on where the problem is, you get very different symptoms. For example, if your upper motor neuron degenerates or has dysfunction, what you mainly have is increased tone in your muscle. That's called spasticity. It's kind of stiff and difficult to move. And when neurologists examine, we see brisk reflexes, like your biceps jerk is quick or knee jerk is brisk. That's what we see when your upper motor neuron is not functioning normally. In contrast to that, if your lower motor neuron degenerates, your anterior horn cells to your muscle gets disrupted, what you have is weakness, obvious weakness of your muscles, and then your muscles disappear, what we call atrophy or wasting of the muscles. Your muscle tone is, in contrast, get very low, meaning it's easy to move around your joint. And when we examine you, the reflexes are decreased, and sometimes muscles jump, or what we call fasciculate. So you can see that depending on where the problem is, you get different kind of symptoms and signs. And in ALS, we see both upper and lower degeneration, so combination of all of this. But as you can imagine, in PLS, only the prominent part is upper motor neuron degeneration. So mostly you see stiffness in the muscle, spasticity, and just a little bit of weakness, just a little bit of wasting, but they're not prominent. You can kind of see in this previous case descriptions and what I told you about the neuroanatomy, those key elements for PLS diagnosis. It's very insidious, gradual onset, spastic and mild braces. It's adult onset disease, and it doesn't usually have family history or gene that causes the disease discovered. There's a gradual progression of the symptom with sometimes spread to the other regions of the body. And when we examine you, clinical findings are typically limited to corticospinal tract dysfunction. Now, we don't usually find evidence of lower motor neuron degeneration. Otherwise, we might think this is ALS instead of PLS. And we also want to make sure that this is not coming from other problems, such as infection. Some viral infection can cause you similar symptoms like HIV or HTLV. Vitamin deficiencies, sometimes vitamin B12 deficiencies can cause you combined degeneration of your spinal cord, which can give you stiffness in your muscles. Inflammatory demyelin disorders, like sometimes progressive multiple sclerosis, can look a little bit similar like PLS. Parkinsonism, Parkinson patients get slow movements in their limbs and sometimes can look similar to PLS. Or compressive lesions in the spinal cord, we commonly have degeneration in the cervical spine, where your disc can push down on your spinal cord and it can increase your muscle tone and reflexes. Now, based on our knowledge and case descriptions, there have been multiple attempts to come up with diagnostic criteria, such as Pringles criteria in the past. The most recent consensus diagnosis criteria is by Turner in year 2020. And the key points in that diagnostic criteria is the presence of age 25 and over. So this is adult disease. Symptoms of progressive upper motor neuron dysfunction for at least 2 years. So there's some duration that's required to make the diagnosis. And then signs of upper motor neuron dysfunction that's not limited in small areas, but affecting multiple regions of your body. And we also need to exclude if there's extensive sensory symptoms unexplained, or there's active lower motor neuron degeneration might put you in ALS rather than PLS, or any other alternative diagnosis that you find on the lab studies, such as infection or deficiencies of vitamin that I explained before. Now, additional caveat that they put on, they try to put diagnostic certainty for PLS in similar way with ALS diagnostic criteria by introducing probable PLS defined by the absence of significant lower motor degeneration for 2 to 4 years from symptom onset, and then definite PLS once you have only upper motor neuron degeneration for 4 or more years from symptom onset. So you can see that the idea is that if you had this upper motor neuron only symptom for longer period of time, then we think your PLS diagnosis is more confident or secure. Now, I have some thoughts about that from our own study. I'm going to get to that later. So I think many of you might think about or thought about this. We hear a lot about PLS, but also ALS. Are they two different diseases, or are they on the same spectrum of motor neuron disorder? Obviously, we don't have a clear-cut answer yes or no for that. We sometimes say, kind of jokingly, are you a clumper or are you a splitter? So clumper is someone who would think, oh, ALS, PLS, they're all the same disease. Splitters are someone who would, oh, PLS is definitely different from ALS. They're two different diseases. There might not be one answer. We do know that motor neuron disease is kind of in a spectrum. So if you see this diagram, you can see that there's upper motor neuron direction, there's lower motor neuron direction, and then there's also inherited diseases and sporadic diseases. Now in the middle, ALS, amyotrophic lateral sclerosis, has both sporadic forms and familiar forms with genetic variants. And it involves both upper and lower motor neurons. That's why it's in the middle. And if you see, look at the left side, you see spinal or spinal bulbar muscular atrophies. Those are genetically caused lower motor neuron only disorders. Progressive muscular atrophy only involves lower motor neuron, but without genetic mutation. Now, on the other side of the spectrum, you see upper motor neuron predominant diseases, such as hereditary spastic paraparesis and primary lateral sclerosis. Now, hereditary spastic paraparesis is usually driven by genetic variants, while primary lateral sclerosis in large is a sporadic disease. Now, one key features that people might quote to say that ALS, PLS might be in a very similar spectrum of disease or might be even the same disease is that they have shared pathology. And pathology is important because even when the outside phenotypes may vary, if the pathology is the same, then essentially those two diseases have a same root. For example, ALS and FTD, frontotemporal dementia, are often discussed together despite of their very different phenotypes. And that's because both diseases are predominantly TDP-43-driven diseases. Now, TDP-43 immunoreactive cytoplasmic inclusions are found in more than 95% of ALS cases. So we can say that this is a dominant pathology of ALS, even though we don't know for sure if the TDP-43 is the cause of neuronal degeneration or just a byproduct in that process. Now, what about PLS? There are a small number of studies that's shown that if you do an autopsy of the PLS patient, which is difficult and rarely done, you can see that there is TDP-43 inclusions like you see in this slides, like B, E, and F, those brown staining in the neurons, typically in the cytoplasm, those are TDP-43 aggregated inclusions. You can see them abundantly in motor cortex, meaning that in the upper motor neuron cells, of course, you see a lot of them degenerated, but among those who's remaining, you see TDP-43 inclusion. Now, what others noted is that if you look at the spinal motor neurons, that's in the anterior horn of the spinal cord, most of the spinal motor neurons are spared, meaning they're still living. However, you still see small amount of TP43 inclusions. Now, what does that mean? Perhaps in PLS, this is still same TP43 driven pathology, but somehow the lower motor neurons, the spinal motor neurons, are largely spared of getting those TP43, and perhaps that's why they are still surviving. And that argues maybe PLS is on the extreme of the ALS spectrum. Now, TP43 is a very interesting protein, and of course, it's currently in the center of motor neuron research. Now, TP43 stands for TAR DNA binding protein 43, and is highly conserved nuclear RNA DNA binding protein. And it's usually located in the nucleus. However, in abnormal situations like in ALS, it gets dislocated in the cytoplasm and it aggregates. Its main role is the regulation of RNA processing, also RNA regulation in the cytoplasm. And TP43 aggregation is found in multiple diseases such as ALS and FTD prominently, sometimes in Alzheimer's spectrum disorders like Alzheimer's disease and late limbic predominant age-related encephalopathy. And many researchers argue that TP43 has prion-like spreading pattern, meaning that it's a protein, but it acts like an infectious organism like a virus. So TP43 can accumulate and kill motor neurons, but it can also get spread to the nearby cells, such as microglia, astrocytes, oligodendrocytes, or the other neurons as well. So this is an actively researched field in order to treat motor neuron diseases like ALS. It may be pertinent for PLS as well. Now, we looked at metabolomics changes such as lipidomics, how the lipid mediators are changed in people with ALS and PLS. And Dr. Era Gomez, Dr. Hiroshi Mitsumoto, we published profiles of blood lipidomics among ALS and PLS patients. And you can see in this figure, many of the changes we observe in PLS are in the very similar direction. For example, triglycerides is increased in ALS PLS. Monoacylglycerols or sphingomyelin, those are increased or decreased in ALS and PLS. You do see that the changes are more extensive in ALS. It's happening in more lipid molecules than PLS. And also at 2-year follow-up, PLS mostly have stable lipid changes, while the changes certainly evolved in ALS patients. Using these differences between ALS and PLS, I worked on this database with Hiroshi, and we were able to show that just by using the lipid profile, we were able to differentiate PLS and ALS separately without their name tags. And that was amazing because the separation was complete. We were able to tell exactly who had PLS and who had ALS. And some of the lipid mediators that we used who contributed to the model were monoacylglycerol species, sulfatase, acylcarnitines, and these levels were very different between PLS and ALS patients. Also, it was able to differentiate PLS from healthy controls between the bloods. Now, another part that I might say how PLS is very different from ALS, obviously, is the rate of progression and their survival. We do know that PLS is a slowly progressing disease, but it's difficult to say how slowly, how is that compared to ALS? Now, if you see this left side figure, red dots represent ALS patients and blue dot represents PLS patients. And x-axis is a monthly BMI change, how much of BMI is changing every month. And the y-axis is monthly change of ALS FRS scores. It's a functional rating scale commonly used to represent the disease severity in ALS. Now, if you have a higher change in ALS FRS, that means you are more rapidly deteriorating. If this is not changing, meaning close to zero, that means you are very stable with your function. You can see that ALS, people with ALS are changing quite rapidly. They're scattered all over the graph here, and some of them losing 5-6 points every month. While if you look at the blue dots, they're really not using much function in terms of ALSFRS score in a month. They're very close to zero in most of the time. And similarly, they don't really lose weight. They keep their BMI stable over months, while people with ALS lose a lot of weight and their BMI is changing quite rapidly. And there's a correlation between BMI loss and functional change among people with ALS, while we really don't see the relationship between BMI and functional change. And both of them are minimum in people with PLS. Now, when I look at the survival, how they're living, how they're dying, this is a typical survival curve where you start everyone's surviving at month 0. And as time goes, you see this curve coming down in red, meaning that people are dying. And when it reaches 0, that means everyone died. And you can see in the ALS population, really everyone died after month 90. That's about slightly more than 7 years, close to 8 years. Everyone's gone. Now in PLS, most people are still surviving, even at the close to 90 months period. So PLS is really not causing a lot of death. We commonly quote that people live their full life with PLS, although that might not be true for everyone. Now, I showed you both aspects, how ALS and PLS might be similar or different. Now, in the end, I think PLS diagnosis is still essential. Now, why is that? The newest ALS criteria, the Gold Coast criteria, will not qualify people with pure upper motor neuron dysfunction for ALS, meaning that we really can't diagnose you with ALS, even there's some similarity. This means that we do need a separate PLS criteria for this population. And this PLS population would not be enrolled in ALS trials in the past and also in the near future. So we need a specifically designed clinical trials for this population. I think it's also very important to study PLS because we can better understand upper motor neuron pathology in this population that's difficult in ALS because of combination of upper motor neuron and lower motor neuron pathology that's already existing. And then we can develop specific therapeutics that's targeting upper motor neurons. Unfortunately, PLS is very understudied, and most of you might agree with me. Primary reason, PLS is a very rare condition. You might know that ALS is a rare disease. We have about 30,000 people with ALS living in the United States. Now, we commonly quote, we don't have exact prevalence, how many people we have with PLS in the United States, but commonly quote that about 3 people among 100 ALS people have PLS. So kind of estimating from that proportion, I believe that we have less than 1,000 people living with PLS in the United States. Now that makes it really hard to study, number one, and hard to convince industry to invest and develop medication for this rare population. It's also very slowly progressing disease and chronically debilitating disease. So it's really important to find the treatment, but also difficult to prove that the treatment is effective. Typically not fatal, and that sometimes make funding difficult when we can convince people with source resources to convince that we should invest in PLS rather than something else. And that all makes PLS very difficult to diagnose. It's underdiagnosed and understudied. And so far, I'm not really aware of any specific trial of PLS except one that tried, but we don't have any results so far. And PLS patients has not been enrolled in previous ALS trials. So that's why I think it's important to really change this game and try to improve our understanding in PLS so that more investigators, funding agencies, and pharmaceutical industry would get interested in developing treatments in PLS. Now, I'm gonna change the phase here a little bit. Let's talk about what kind of research has been done in the past. The paper that I quote here from Dr. Sabrina Paganoni and her colleagues, and they were also agreeing that PLS was very understudied. They attempted this project, and they reviewed 250 PLS patients who were included in the NEOS consortium database. And they spent a 15-year period of data accumulation. They mainly used ALS-FRS, the ALS functional rating scale, to look at how fast they deteriorate with their disease. What they found is that ALS-FRS-R, the total score, changed about 1.6 points every year. Now, how big or how small is that? We usually think that ALS-FRS decline about 1 point per month in ALS patients. So this is about 10% of progression rate compared to ALS population. Now, similarly, vital capacity also declined very slowly over a year, just 3%. And from this data, they estimated if we want to have a successful clinical trial to show the efficacy of the medicine, we need about 2,000 PLS participants. Now, if you think about it, I mentioned that we might have somewhere less than 1,000 people with PLS in the United States. How are we going to recruit 2,000 participants to make a successful trial? It sounds very daunting and almost impossible. So that made us think, is that really impossible, or is there some way we can get closer to PLS clinical trials? And there are some ways to improve this, to solve this. And importantly, we need a better outcome measures that really can reflect the function of PLS participants more sensitively and accurately. We might also need to identify subpopulations who will be ideal for the trial. For example, we don't enroll everyone with ALS in the trial. We focus on subpopulation who might be closer to the symptom onset, who might be progressing a little bit faster, who might have more definite diagnosis. So these kind of criteria to identify subpopulation should also apply to PLS trial. We can develop and utilize blood and imaging biomarkers. We can be more accurate and more sensitive to changes. And we can, of course, we need to identify novel therapeutics that really works for this disease. That's, of course, very important. So for this, mainly Dr. Mitsumoto and his colleagues put a lot of effort in developing this scale specific for PLS functional rating scale. And the idea was that we don't have a good scale for specifically designed or thought of for PLS. And ALS-FRS was not sensitive enough. Now, how was this scale developed? They had a lot of meetings together with a focus group, of course, experts in motor neuron disease, ALS, PLS, but also patient advocates were participated in these meetings. And based on the ALS-FRS that we were already using, introduced intermediate scores from items 1 to 10. For example, in item 1, we ask about the speech. How's your speech? Is your speech normal? Is your speech changed and detectable speech disturbance? Do you need to repeat yourself because people cannot understand you? Or do you need to combine speech with non-vocal communication, such as writing or typing, or you don't have any useful speech? So those are the items for ALS FRS scale. Now in PLS FRS, 2 more items added. You can see in number 5, occasional speech disturbance. So your speech has changed, but you noticed a little bit, but not really detectable to others. And number 3, alteration in habits to improve speech. For example, you are missing, if S is difficult to pronounce, you're changing that to something else. So by introducing some intermediate items, we are trying to catch the progression more sensitively. And this process has been done from items 1 to 10, so making the total score from 48 to 68. And in that study, the authors have shown internal consistency, intra-rater, inter-rater consistency, and test-retest reliability and construct validity. And all of these means that the scale if you do it over and over again, reproduce similar or same scores, and it's not really changed by who's doing this, who's applying this scale. So different raters produce similar test results. So it's validated in that sense. Now, the authors also identified that PLS-FRS show more changes over time. You see in this red graph that the slope is steeper a little bit compared to ALS-FRS, which is in green. And even this small difference in the slope would really help clinical trials to reduce the sample size that's required to show efficacy. Now, this effort needs further validation. So that was a small study. Now, what we are doing is a prospective multi-center study. So we are recruiting PLS participants from across the United States and Canada, 30 sites. And so far, we enrolled 75 participants. The enrollment has completed, and we are still following them. The 2-year follow-ups will be completed this fall. So at this point, we have completed 1-year follow for everyone, and soon we'll have 2-year follow-up completed for everyone. The aims of this study is to develop this natural history data set, and it's valuable that we have a prospective cohort. So we are designing to follow this cohort and collect important data points and samples, such as blood samples. We will evaluate the difference in disease progression in early PLS and well-established PLS. Importantly, we included early PLS who had short disease duration to see whether the progression is different in this subgroup. And we will evaluate the accuracy of consensus diagnostic criteria in differentiating ALS and PLS. We'll also follow how many of these participants would rather convert to ALS in the future. And we're collecting biosamples to analyze many different things, including some of the genetic examination. Is there any genetic mutation that causes PLS, or PLS is truly sporadic disease? We're going to look at various biomarkers that can help us distinguish PLS from other diseases, and also biomarkers that can predict us with the disease progression in the future. This cohort has really a lot of strength, but most importantly, large sample size for PLS. I said 75, that sounds like a small number, but if you think about, less than 1,000 people living in the United States, we are recruiting close to 10% of the US PLS population. We have very comprehensive collection of outcome measures, not just PLS-FRS, but close to 10 functional outcome measures. We are also collecting information on conversion to ALS diagnosis. We're collecting biosamples such as blood samples. And importantly, we introduced this concept of early PLS, and I'll tell you later why that's really game-changing. Early PLS we defined here in our study for the first time as people who has PLS with disease duration less than 2 years. Now, I told you in the diagnostic criteria by Turner, you need 2 to 4 years at least of disease symptom duration to get diagnosed with PLS. Now, we thought that might be missing some early PLS participants. So these are the people who may not even get the official PLS diagnosis, but we wanted to include them because they don't have ALS, they have just upper motor neuron dysfunctions. And at this time, we can't really classify them as PLS, but we want to see how those people progress along with more probable and definite PLS diagnosed people. And the study was well planned, so they were included from the beginning, same with other PLS participants, and we are learning something important among this population. Now, what are the important information we learned from PLS natural history so far? Many of you might be interested to learn or anxious about PLS converting to ALS, and that's something we see on and off, and there's really no great way to predict. There hasn't been any great way to predict who's going to later progress to ALS. And what we did, we mandated all PLS natural history cohort participants to get EMG evaluation as well as investigator evaluation at 1-year follow-up. Now, EMG is a very sensitive test to detect lower motor neuron degeneration. So even when the muscle strength is normal on neuro exam and you don't find obvious evidence of muscle atrophy, the EMG needle, if you put it in the muscle, can tell us whether your muscle is getting detached from nerves because of lower motor neuron degeneration. And we found that uh, 5 out of 75 participants, so about 7% of the participants, met the diagnostic criteria for ALS at 1 year follow-up. So that's kind of consistent with the literature. It's not common. It's not very rare, but we see them. We were interested to see whether this conversion was happening more so in the early cases than the later cases. So we compared the frequency of conversion between early, probable, and definite groups. Now, to our surprise, there was no ALS, no early PLS participant who converted to ALS. They all stayed as PLS. And conversion occurred both in probable and definite groups, and one participant converted to ALS 7 years after symptom onset. So this is quite in contrast with the previous literature that we believe that after 4 years, you don't really convert to ALS. But in this study, we show that even after 4 years, you can still convert to ALS, and maybe a little less than the probable group, but there was no significant difference between those groups, suggesting that really ALS conversion can happen at any point in your disease progression. Now, what we also learned from these different functional measures, we followed them over time at baseline, 3 months, 6 months, 9 months, and 12 months. What I'm showing you here is PLS-FRS that I introduced to you. And also ROADS. ROADS is a commonly used functional measure, mostly in the ALS clinical trials, and it has good interpretability, meaning that 1 point difference has a specific meaning, and 1 point difference is reflect the same across the study points. So we also wanted to compare PLS-FRS and ROADS. You can see in 3 different groups, definite, early, probable, and definite groups. Early PLS group had most rapid functional decline, although they started with highest functions. So higher score meaning better function. And compared to early group, probable and definite PLS groups had slower functional decline represented by slower slopes. And by calculating this rate of decline, we were able to calculate how many people would be needed to show efficacy of the medications. For example, if the medications designed to show 30% difference in disease progression rate, how many people do we need to show that the medicine's effective or not? And we came up with the number somewhere around 300, 350 people might be adequate to show that the medicine works if we recruit these population similar to our PLS natural history study cohort. Now, if you think about the rate of progression, if you recruit more of the early PLS participants who progress faster, we can even reduce this number quite a lot. So I think in the future, the key of having a PLS trial is to identify a pathway. We can identify early PLS participants, and that's going to drastically reduce the sample size. Another important point we found in this study is that we saw that PLS-FRS is not only showing sensitively the functional decline, it also correlated significantly with all the other measures. So for example, PLS-FRS and ROADS, they had 0.85 of correlation coefficient, meaning that they're effectively very similar scale. They go hand in hand with each other. PLS-FRS also correlated very well with actual functional measures, such as finger tapping, the number of finger tapping you can do like in a minute, foot tapping, the number of foot taps you can do in a minute, or pataka, like how many patakas can you do in 1 minute. Those are direct functional measures of your muscles, and PLS-FRS had a good correlation with those scales. It also had good correlation with your quality of life measures that we introduced in this cohort. they correlated with your function of walking, like timed up and go. Some correlation with breathing tests, like vital capacity. So it demonstrated to be a good primary marker that can be used in clinical trials. So I think those are important points we saw in this study. Now, I mentioned that we don't have a good marker for this disease, either for diagnosis or progression. We tested whether neurofilament, which is a prominent marker in many of the neurological disorders, including ALS, we try to see if neurofilament can tell us who's going to convert to ALS in the future and how fast you're going to progress in the future. Now, both cases, the answer is yes. We saw that if you have high blood neurofilament light level at enrollment, it predicted how likely are you going to be converting to ALS at 1 year, or how likely are you going to progress faster than the other people. So I think both points are really relevant in clinical care, and we are measuring neurofilament in all of our patients in the clinic, both ALS and PLS. And I think that should become a standard of practice in the future. It's a very prognostically helpful marker. So I hope I have given you some exciting and interesting results so far. Now, I'm sorry that I couldn't show you some graphics, some graphs in those slides, because we haven't even presented this data in the national meeting. We submitted an abstract for presentation. And of course, those are not published. So I was just trying to give you a highlight of what we found in the study. And you're going to hear more about them in the coming national meetings and also in the literature after we publish this. Now, I think we've got a lot of valuable information so far, but still there are a lot of remaining questions. PLS is a very chronic disease, and we only had 2 years of follow-up. Now, 2 years might be long enough for ALS, but really not for PLS. You have PLS for 5 years, 10 years, 20 years. So we wanted to follow this cohort, that established cohort, a longer period of time to have better understanding of the history. Especially, I'm interested to see whether this early PLS group who had a rapid decline later become a slow progressor, or whether those rapid decline in early PLS just continues in the later stage of years. So that would be an important point that we're going to identify in the longer follow-up. And also there's a need to further think about ALS conversion. We only looked at 1 year and how many people convert to ALS, but we don't really know what happens to this early probable or definite group in the later 2, 3, 4, 5 years. So those are also the important aspect of this cohort we're going to follow. We have collected a lot of data and samples, but we haven't really analyzed them. So we will focus on thinking about, we found neurofilament to be an important biomarker. What other biomarkers are we going to analyze or examine? And I think there are unlimited number of options, and we'll join forces with basic scientists and those with metabolomics experts to further identify important markers for diagnosis and progression by using these samples. And with this, I'm really excited to tell you a little bit about extended PLS natural history study. And this is really needed to look at our established cohort beyond the 2-year mark. And we plan to follow this cohort for 5 additional years and collect patient-reported outcomes. Now, the important introduction of this extension study is that we're going to use a patient-friendly online platform, so you don't need to visit your site, or you don't need to even talk over the phone. We'll help you complete these outcomes over the online site that's secure, and you'll be able to finish these outcome measures at your convenience. And it will not be any more difficult than talking to someone over the phone. And gratefully, NeuroPRO, this platform was developed by Harvard, and they would help us with this platform and help collect those outcomes through this online platform. And we will include these number of measures, PLS functional rating scale, of course, but we also developed self-report version of the PLS-FRS. So Previously, we were getting this information over the phone by someone interviewing you, but the self-report version of this would you be self-reporting. And we're going to see if those two versions are interchangeable. We're going to collect a road scale as before, quality of life scale, and we're also going to ask what's the frequency of using this durable medical equipment, such as wheelchair, walker, and so on, and whether you had change of diagnosis to ALS and the survival. Those are the important outcomes we're going to collect. And then we're going to use the blood samples that's collected to analyze not only neurofilaments, but one of my interested field, metabolomics and lipidomics, to see if any of the metabolites can really tell us about the disease itself, to tell us about the pathways and tell us about the disease progression. It can be used as a prognostic marker in PLS. So I think I'm on time. So I think this is all I have, and I hope that you learned something during the past hour, and I'll be happy to take any of your questions.
Thank you so much, Dr. Lee. I learned a lot and I really appreciated the information that you just shared. And I have several questions myself that I would like to ask, but I'm sure that there have been people over here in the chat box patiently waiting for their question to also be answered. Peter mentioned something about a benefit of a vibration plate. Are you familiar with that? And then my legs, I've seen recovery of my cervical nerves. You can see that question there if you don't mind. Do you have a thought about that?
Interesting. No, I heard similar devices from my patients as well. It can be vibration plates, it can be a compression and devices, it can be stimulating devices like electrical stimulation. I think all of those devices are targeting to passively stimulate your muscle. And the thought is, if you somehow give signals in your muscles that doesn't get good signal from your brain, perhaps that might stimulate your brain to recreate a pathway toward that muscle. Now, the short answer is I don't know. Those devices are commonly not vigorously tested or examined. Many commercial entities would still introduce and recommend those devices without evidences. So all I wanted to say, when you think about a device, when you think about the medicine, supplements, think about the downside first, side effects. Is that going to cause you any trouble? Think about how much of economic burden is going to put on you. So make sure it's not breaking your bank. And if there's efficacy evidence, great, but I think commonly they don't have efficacy evidence, especially in the PLS specific efficacy. It's okay to use them if you think it's safe and it's not too expensive. If it's too expensive, I'm a little concerned. Some people try to make this as a lucrative business, so just be careful.
Yeah, thank you so much, Dr. Lee. I really appreciate your comments. And we've already had 2 different SPF talks about neurostimulation. So I would encourage all of you on screen today to take a chance to look at that. We also even sent out an e-blast about that as well. So you can find all of those links in your email box. So I want you to get a chance to y'all look at that. And then we had Jose that talked about the TDP43 is not a universal finding in PLS. I don't know if you can see that comment over there. You might scroll back.
So when you say a universal finding, I agree. It's probably not a universal finding. And the slide I showed you, those are case series. And what the case series means, when authors saw a series of cases with those findings, they reported. The problem is there's a report bias, publication bias. Let's say I studied 5 autopsy cases and I didn't see TP43. I might not report this because it may not get published easily, and the negative finding usually are considered less important than the positive findings. So there hasn't been a large case series like 30 or 40 where they look at all the autopsy cases and tell you how many of them had these cases. But those published cases are probably a little bit biased toward positive cases. So I don't know which article you're referring to, but it's probably not a universal finding. But still, I think it's important to learn that many of the autopsy reports show that TP43 are found in PLS participants or patients.
Thank you so much, Doctor. Again, there's more questions about this being videoed or sent out as a tape. Yes, we will put that on the YouTube channel, so please be looking for that link. And then we also ask about, will this study change the PLS FRS soon? Will it be published?
PLS FRS scale itself is already published. And I have my reference article included in each slide. The PLS FRS was developed and published and validated. Now, the PLS FRS results from this PLS natural history cohort that I presented to you. It's currently in draft to get submitted. And I'm hoping that this would get published later this year or next year.
If you don't mind, Doctor, whenever you have a chance, send us that as a PDF, the one that has already been published, and then obviously the one that's going to come out. That would be wonderful, so that way we can share that information as well.
Sure,
So,
I can send you the published version.
okay, so what I really heard in some of the conversation is that you're needing more patients, right? We need to identify 300 to 350 patients that have PLS and more if possible. So, I mean, that surprises me that we don't have that number available for you. And I would think that we have many of those folks that are in our database. So we need to be trying to get the word out that if people have PLS, they need to be reaching out to us so that we can have that information available. So that if you've got something that they need to be doing, we need to send that information to them so they can connect with you. So that's wonderful to hear. I appreciate your clarifying that.
Yeah.
So somebody asks, is there a PLS research project that I can volunteer for?
Now, I would love to have another PLS project. Now, this one, we stopped recruitment because the extension part would only gonna follow on the online platform as I introduced. Now, if there's another PLS study, I'm certainly going to be advertised through the SPF. So you follow with Norma.
Yeah, so that's what we've got to do is we've got to get our folks to understand that they need to be a part of the membership of the foundation so that we can let them know, that we can let you know how many people that we have in our database. We can easily meet 300, 350 people. I mean, not only what's in America, but there's some other folks that are in other countries that may also be able to come in and work on being a part of that study.
Right? It's likely going to be international collaboration. We really can't do it just among us.
Right.
We might include European colleagues, Asian colleagues to do
Yep.
the trial.
Yep, we need to do a call out on that, guys. So what about, can you talk more about the neurofilament blood test levels and how this reflects PLS?
So neurofilament is a protein that's in your neurons, in the axon. And when your neuron degenerates or your neuron gets damaged, this protein comes out in your blood. It's not a specific marker, meaning that the level is elevated in many of the neurological conditions, including ALS, PLS, but also Alzheimer's dementia, Parkinson's, stroke, multiple sclerosis, you name it. So it's not a specific marker. However, the level is very high in ALS. We saw that the level is in between the normal and ALS for PLS patients. Now, the level might be low, level might be high. Why is that important? I showed you that when the level is high or very high, it predicted a faster progression and also probability that you might convert to ALS. And we were going to put in specific level of blood neurofilament in our publication that predict the conversion to ALS. So that's something that you can ask your clinician, and it's available through multiple labs. I usually send mine through LabCorp as one of the commercial lab, and it's just one blood test.
That is wonderful. Thank you so very much. Okay, can you please give me more information about people diagnosed with HTLV?
Oh, HTLV is a virus that likes to attack your spinal cord. It's a very rare infection. It's not a common infection. Sometimes I check HTLV PCR in the blood along with HIV, but obviously, you don't always have to check it. You can, and it's a blood test.
Thank you so much, doctor. So can you elaborate a little bit on this new drug that has been sponsored by Biogen? That it is called, and I'm going to mispronounce it, I know, but it starts with a Q, Qalsody, Colosity.
Qalsody.
That's
Qalsody is a gene-specific medicine targeting SOD1 gene, and it's currently FDA approved for treatment of ALS patients with SOD1 mutation.
okay.
Now, there has been some interest whether Qalsody can be applied to sporadic ALS patients. There hasn't been any substantial data that shows it can be applied to sporadic ALS or PLS. I don't think there's any data that Qalsody can be used for PLS. Now, SOD1 is distinctive from other ALS patients with TDP-43 accumulation. SOD1 patients have SOD1 inclusions in their motor neurons. So my personal feeling is that it's targeting a very pure small population,
Okay.
and probably it's not a good candidate for PLS.
So do patients with PLS, they have a different gene mutation? Everyone has a different gene mutation?
So PLS patients typically have no family history, typically don't carry any pathogenic variant. There's no gene mutation that's identified to cause PLS. Now, very few PLS patients have C9 or 72 gene, which also commonly cause ALS or frontotemporal dementia, but that's a very rare cases.
Okay, very good. Let's see. I don't see any other questions. Does anybody have any questions that they want to come on screen or they want to continue in the chat box?
I
Anybody?
really more questions?
I thought I heard somebody say something. Can you stop sharing your screen, doctor?
Sure.
That would be great. Now, anybody else have a question? If you can't see the little raise your hand kind of thing at the bottom, you can just wave at me. Okay. I don't think there are any other questions, doctor.
I just want to say, I mean, I'm presenting here, but a large part of this work has been done by giants in the field. Of course, Hiroshi Mitsumoto, Dr. Mitsumoto has done a lot of work to help PLS field. Along with Hiroshi, investigators in the PLS natural history study, investigators, participants especially helped produce this data. And I'd like to really appreciate support from Spastic Paraplegia Foundation, Norma and Greg, and other committees. I'd like to help all the funding bodies, and hopefully we can do more exciting and important work in the field.
Thank you so much, Dr. Lee. There are two people here just real quickly that have got questions. Tina and Tim Krogan, your hand come up first. Dina, you're on deck.
Yeah. Dr. Lee, I was just wanting to know, I have HSP SPG7. And so I was just wanting to know if you would like to have those patients too to join the clinical trial to fluff out your search area.
So HSP is a similar disease, but as I showed you in a slide, it's a spectrum with genetic mutation, like you said,
Right, right.
the specific genetic mutation identified. Now, I think the probably more efficient way to develop therapeutics for HSP is to target that specific gene to understand how that gene was originally functioning, and then how is that function changed because of the mutation, and intervening with the medicine to target those aberrant pathway might be more yielding. However, if we do, let's say, a symptomatic trial, we are trying to help your spasticity, we are trying to help you move better. Now, those medications can apply both to HSP and PLS populations together. I think those pragmatic or those symptomatic treatments should also be developed because it's a very indolent and chronic disease. Symptomatic treatment might also improve your quality of life.
Okay.
Thank you so much, Dr. Lee, because I know that on the previous conversations that Dr. Fink has had regarding HSP and PLS, he does like this monthly support group discussion, and he talks about there are like 5 different kinds of PLS. and one is HSP7 that could eventually maybe turn into actually being PLS. So I'm thinking maybe that's what Tina was, kind of alluding to, is that he's explained that to everybody, saying that there's this correlation of similar pathway, and that, so that might open the door for more patients to actually recognize that commonality and be a part of that study.
Yeah, that's very interesting. I mean, obviously there are different thoughts about how to draw the border between a PLS and HSP. My understanding was that if you have a genetic mutation that defines HSP, those SPG genes, then you are classified as HSP rather than PLS. But nothing's really set in stone, and those criteria are also evolving. So we might have an interesting discussion between Dr. Pink and I in the future.
Yeah, that'd be good.
Where you belong to.
Yeah, I mean, that's it. That we just, we're all a part of the same family. We just want to figure out how we're getting there, and how we can actually get some kind of treatment or therapy that can stop and improve some of these symptoms that, these symptoms are terrible, and we need to find ways that we can help improve the quality of life. Dina,
Right.
you got a comment or a question? Go ahead, dear.
Well, comment on just what you were talking about. Yeah, I've heard that there's some sort of a link between SPG7 and PLS, but I have no idea what that is. My question, I'm just more curious. I know that you answered the question as far as how that drug with the Q
Calcite.
yeah, it won't work for PLS, but just curious, what does it do?
What does it do?
Yeah.
Okay. So what Qalsody do? Qalsody is an antisense oligonucleotide. And when you inject the medicine through your intrathecal space, you put a needle to your lower back, and the needle tip would reach your spinal canal, where your brain and spinal cord is floating in the water, what we call spinal fluid. And when the medicine is introduced in that space, it gets absorbed in your brain and spinal cord, and it starts reducing the production of SOD1 protein. I told you that in SOD1 ALS patients, SOD1 accumulates, and it has a toxic effect on your neurons. And the accumulation is because of abnormal protein being produced. So the medicine is just down-regulating, inhibiting your protein production. So your accumulation of the SOD1 is decreased, and your neurons would survive longer. And that's how the medicine is helping you.
We want to thank you so very much for today and for the time that you put into this, and we'll look forward to the next talk.
Oh, my pleasure. I'm really honored to be here. I really enjoyed being with you. I would need a lot of your input too. So let's stick together, work on this disease, and hopefully we can have some treatments for PLS.